Our final guest speaker of the day is Dr. Kelly Shaw. While the Newfoundland Labrador Medical Association and others were researching reform initiatives and the principles of health system planning in other parts of the world, we were inspired by the role delineation framework implemented in Australia, particularly in Tasmania. We are extremely lucky today to have Dr. Shaw with us all the way from Tasmania to discuss the Tasmanian role delineation framework, One State, One Health System. Dr. Shaw works as a clinician, public health physician, health services manager, and consultant in the healthcare sector. She has developed numerous health services practice standards and guidelines across Australia. She was the lead clinician that developed the Tasmanian role delineation framework and clinical services profile. This work provided the blueprint for health services reform in Tasmania. Please join me in welcoming Dr. Shaw.
Thank you very much for having me here. It's 3:30 in the morning where I'm from, so I feel like I've just come off a long run of nights, but we'll see how we go. This is, of course, Australia, where I'm from, and it's a country that has 8 states and territories, and that little tiny island down the bottom is Tasmania, which is the place I'll be talking to you a bit about. So it's a small island off the world's largest island or the world's smallest continent, whichever way you choose to look at it. I've been struck by the conversation this morning and the feeling that I haven't left home at all, because it feels like we're talking about exactly the same things. My purpose here today isn't to tell you how to do things, it's to give you a case study of what we did, and hopefully from that any ideas that you think are useful to use those and appropriate them. We like to say share generously and steal shamelessly, and I feel like I've just stolen shamelessly off David and some of the speakers this morning, so this is my turn to share, I guess. We have a fairly complex system of funding. The state governments or our regional governments fund our public hospital networks. The Commonwealth Government or Australian Government fund primary health care, most of our community health services, and our private hospital system, which is also subsidised through people having private health insurance. That's relevant, I think, because as with any of these things, there are some similarities between our systems and some very big differences. And when I talk about the role delineation process, it's got a focus on the public sector acute services. That's because this was the state government leading it, and is the bit of the work that I can talk to, but to also say that we've got parallel processes for our preventive health and health plans, our primary health services, and looking at how we use public hospitals. So just like you, I can show you lots of graphs with lines going up. There's our total health expenditure adjusted for inflation. And in terms of where the money goes, the biggest chunk of it's on public hospital services. There's another big chunk that's on primary health care, but when you unpack that, actually a lot of that spend is on medication. So it's not going to clinicians' salaries. So in terms of Tasmania, we have a fairly parochial, somewhat regional distribution of our population. About 250,000 people live in the south, and another 250,000 people live in the north-northwest, so we're at about 500,000 people. We have the highest median age of any of Australia's states and territories, with a bit younger than you are. We're sitting at about 16.5% of our population are 65 and above. We've got the highest percentage of any state or territory that have people with self-reported disability. So that's somebody with a core activity restriction that requires assistance. In other words, they need a bit of help to get through their day-to-day. We've got the lowest average household income of any of the states or territories. And because of our social determinants of health, poor income, education, employment, difficulties with housing, transport, unsurprisingly, we've got lower life expectancy at birth compared with the Australian average. So the dotted lines are the Australian averages. The one with the spots is our Tasmanian females, and the one that's a straight line's the Tasmanian males. So girls live longer than boys, but we've never actually managed to catch up with the Australian averages. We've also got the highest rates of multimorbidity, so this is adults who report having 3 or more chronic conditions. So, we're old, fat, sick and poor, and fairly geographically dispersed as well, with our biggest hospital, which is that one down on the bottom right, the Royal Hobart Hospital, sits in the south, and then across the north-northwest, we've got 3 other big hospitals. We've also got 19 little rural hospitals, and we've got a swag of private hospitals as well. So a lot of hospitals, given that hospitals don't actually influence the health of the population. It's frustrating, I guess, with my public health hat on, but that's where most of the money goes for us. And in terms of the bed sizes, down the bottom you can see how many beds we've got in each of the hospitals. So over time, what we've seen is a fairly healthy and sometimes unhealthy parochialism with this many hospitals for this few population, where our clinicians argue about who's the cleverest, who should be allowed to do the most, and get very grumpy when people don't refer the things they think they should be seeing. And on the flip side, a lot of our rural practitioners who want to know about how to do things rather than where to send things. And we've had some scope of practice issues over time where we've seen a lot of duplication across our hospitals. Most of our duplication is surgical, because we've been stuck in a political cycle where people think that access to good care means access to care that's as close to your home as humanly possible. And as a result of all of that service duplication in surgery, which has soaked up most of the money, we've got service gaps in just about everything that's not surgery, so particularly medicine, paediatrics, and our subacute services, so rehabilitation, palliative care, geriatrics, for example. And that's on a background of, as with many other places, an increasing number of overnight hospitalisations. So, the first thing that we had to do as a part of our reforms, and I'm entering the health reform story really part way through what is an iterative process. This isn't the first time we've been reforming. It's probably not the first time you are doing health reform. It certainly won't be the last, because each time we go through a change process, we make a bit of ground. There are lots of trade-offs, but hopefully we're moving towards a system that's improving as we go along. So that case for change had to be made to capture the hearts and minds of our clinicians, but also, and more importantly, our public. Because if we lost the hearts and minds of the community, then we weren't going to be able to achieve what we needed to in how we redistributed the way that we deliver clinical services. So I'm just going to show you a little video that we put together for consumers and for providers, but really just as a bit of an infographic.
Tasmania's health system has some great things about it. Our nurses, doctors, midwives, specialists, allied health professionals and support staff all work hard to deliver the best outcomes for patients. But the system they're working in is broken, and it needs to be fixed. Right now, Tasmania's 4 major public hospitals work separately, and each hospital tries to do everything. For a state our size, that just doesn't make sense. What does make sense is one health system that shares resources. One health system where hospitals specialise in what they do best. One health system that works together to deliver the best care. Here's how it will work. None of our hospitals will close. Instead, they'll work together along with our regional hospitals and the many other parts of our health system. Our 4 large hospitals will each focus on helping the needs of all Tasmanians, not just their local communities. Highly complex procedures will be performed in larger hospitals, which have the expertise and support services to keep people safe. That means the day-to-day services that are needed by more people more often will be available in more areas around the state. We also want to secure the future of the Mersey Community Hospital, so that it can continue to deliver important emergency services to the local community. We need it to play an important role in improving services for the North West and unblocking elective surgery for the whole state. It doesn't matter where you live, everyone will get access to better care. Fewer people will need to travel for the services they need regularly. And if someone does need to travel to another hospital in another part of the state, then we'll strengthen the transport and accommodation support they need. One health system will also mean less duplication and less waste, so that we can deliver more and better care to everyone who needs it. It's all about creating one health system where everyone works together to give Tasmanians access to the healthcare that they deserve. It's one health system for everyone. You'll find more detailed information about our One Health system here on our website.
This little infographic, I guess, it reminds me of, with our process, that you know, as I said, this isn't the first time we've been through a health reform process. Back in 2009, we had another significant health reform process, and it was much more data-driven, much more about modelling and projections, and it was a good model, no doubt about that, but it really went nowhere, and that's because of the political interference and the lack of clinician engagement and clinician leadership in the process. So in learning from that previous reform, we tried to do things a little bit differently while still sticking to the essence of what we identified in the previous modelling that we'd done. I think that's gone dead. Okay. So we set out an issues paper that really laid it out for the public and for providers, what some of the things that we thought were systems pressures, like increasing expenditure, increasing disease burden, and some pretty horrific statistics in terms of the longest case-weighted separation lengths for a lot of things. We had high cost, high readmission rates, and some serious adverse events. So we tried to approach our reform according to these 7 areas. So in the engagement space, we set up clinical advisory councils. So across our major disciplines, we wanted clinicians to be involved in the major decisions around models of care and service models. We had consumers on those. We also had primary care, general practice was there, and the private hospitals, and we had some honest discussions about what we do, what good looks like for that professional area, and how we get from A to B, how we get from the status quo to improvement. We also set up a Health Council of Tasmania, and the Health Council really took on an overarching role of bringing together the other partners such as industry, our universities, and the community more broadly, and was a mouthpiece for the reform process. Stood alongside the minister, our health minister, so that it could become clear that this was more than just politics, that we wanted to make this as apolitical and as evidence-based as possible, and to provide as much leadership as possible and as much unity as possible in selling the messages. In terms of the governance and leadership, we'd previously had 3 regional health organisations. We had to bring those together as one health service, and that also influences the structure. So in doing that, we had to merge management structures as well as clinical leadership structures and really change the way that people thought about their job. For doctors, nurses, allied health professionals, they thought of themselves as employed by a facility. I work for the Royal Hobart Hospital, I work for Launceston General. What we wanted to do instead was to sell the idea that you work for a health service. This is one hospital with 4 campuses, or one hospital with multiple campuses. And so your role as a provider wasn't just in a facility, it was to that service. So sometimes it wasn't about the patients travelling. A lot of the time it's actually about the providers travelling and delivering that care where it's safe and sustainable to do so, closer to people's homes. I'm going to talk about integrated management and planning through our role delineation process. In terms of resourcing, and again picking up from one of the themes this morning, a really important point was to not make the resource that was being freed up in the system seem like it was coming to a hospital or to the big hospitals. Where you freed up that resource, it had to be reallocated back into that community so that they weren't in net deficit. They had to be the beneficiary of the equivalent amount of resource, but in using that resource to deliver the care that they actually needed, which wasn't more surgery for most of our sites. It was actually about delivering better community care, so enhancing our community nurses and community nursing workforce, bringing in some of our medical models such as paediatric rehabilitation, better community paediatrics, and improving some of those things that had been left to languish over time. And in terms of the resourcing, the other big change was to move to a commissioning model. So for us, that meant that government wasn't any longer block funding a hospital to deliver. What it was doing was it was commissioning an outcome. And as purchaser, that gave the government the ability to influence who did what where, which is where the role delineation framework comes in. So what that means is that as a clinician, I've got the autonomy to, look after a 30-week baby in my facility, but I'm not going to be reimbursed for that as a facility. That's on my head, because in the overarching plan, our role delineation framework says that we're able to do 32 weeks and above. So we didn't actually stop people doing things, but we didn't give them the resource that enabled them to do it. So they had to make more considered decisions, and they had to get their internal management right. In terms of safety and quality, we were looking at quality in its broadest sense, so equity, access, appropriateness, acceptability, not just safety, and looking at the effectiveness and efficiency of our services. The reform wasn't about saving money. It still isn't about saving money. It's about improving outcomes. It's about recognising that regardless of our fiscal situation, the care we deliver to our patients is not achieving the outcomes that it should. It's not. We waste money, we waste money through stupid things. We don't communicate with one another properly. We don't share information. People don't take accountability for their patients, so they fall through the gaps. We're not patient-centred. We go and flog them with a rehab plan or an intensive management when their actual goals of care are for something that's different to that. And so trying to change some of those things and sharing transfers of care, sharing accountability for patients regardless of which setting they're in was really important. And our monitoring reporting processes changed a lot too. Data, I guess, is the enemy of improvement sometimes. And I say that with my public health epidemiology hat on. And really that was because we'd spent a lot of time since the 2009 reforms bickering about the data, and we called it the stages of data enlightenment, from the bottom, which is it's not my problem, your data are wrong and there's nothing to fix, all the way up to, well, it's not my problem, the data are wrong, but it seems to not look right and someone should fix something. It is my problem, the data are wrong, and it's someone else's problem to fix it, all the way up to, well, it is my problem, the data are right, and I actually can do something about fixing it. And that culturally took us a long time to get past this bickering about numbers to say, all right, well, what can we agree on and how do we improve things? Because ultimately it's about the patient. Who knew? So, the Green Paper. The Green Paper came after the Issues Paper. It talked about our strategic direction as a system. Again, we consulted widely. The Health Minister went out and faced angry crowds in communities who were going crook because they thought this was all Machiavellian government stuff, that it was about closing hospitals. He had to work really hard and still has to work hard to maintain credibility with the voter. But to also stick to his guns, which is to make sure that resources aren't pulled out of local communities, but they're reallocated in a way that enhances the health and well-being of those communities. We too needed to shift and continue to need to shift the balance of care from hospital to community, not because family care is cheap and therefore it's no longer the hospital's problem, but because that's where it belongs. With our increasing chronic disease burden, our patients think of a trip to the hospital as like a nasty holiday, but if they're in and of the community, they go into a hospital, they're back in and of the communities where the bulk of care is delivered and should be and continues to be delivered into the future. We needed to redesign a lot of our clinical services, strengthen our public-private partnerships, again, a duplication issue, and strengthen interstate partnerships. With a population of 500,000 people, we don't have enough to do all of the things that all of the people need all of the time. We had already a good precedent for interstate partnerships in that about 20% of all of our paediatric admissions go interstate, because that's where all of the clever subspecialty paediatric people are, and so they should be, you know. They need paediatric neurology, rheumatology, nephrology to be service concentrated so that we can deliver high quality services, not just the doctor. A lot of talk is about focusing on who the clever specialist is. It's actually about the entire team. So if you want to do 1 or 2 of something a year, that's great for you, but what about the social worker, the dietitian, the other people that sit around that team who are really good at it if they're doing a lot more of it versus not so much if they never see a person who needs that care type. A political requirement for us in our reform process was that no hospital would close. And again, we learnt that the hard way through the 2009 review, where we picked out the hospitals that the modelling says should close, but marginal political electorates, we lost the political support for it and it all fell over and we didn't get anywhere. So this time we actually recognised that all things being equal, in a perfect world, we would close some of our small hospitals, but the reality for us was, in the political environment, we needed to make sure that the hospitals we had weren't actually going to have a lot of inappropriate activity. So in terms of the beds, if you're a cynic, you'd say we starve them of activity. If you actually look at it from the evidence, you'd say that the beds aren't very active anymore. They're not used anymore because people are getting in-home care, community-based care, and the things that they actually need. We're not gumming up acute beds with subacute patients like we used to in some of those rural hospitals. So then we developed up a role delineation framework, which is essentially just a tool. You can use any tool you like. For us, it's a blueprint that it provides a shared understanding of the clinical capacity that a health facility needs to have for a specific discipline. It's usually a 6-level thing, and the levels are cumulative. And I'll show you a template figure that illustrates this. So your level 1 services are your low-level care that most people should get in most places. Sometimes they're delivered by providers, sometimes it's by provider assistants, all the way up to your pointy end, which is your level 6 services. Fewer services deliver them, they're technically complex, they're really expensive to do, and we need to, for effectiveness, efficiency, and to get those good quality teams, service concentrate around those. So we had some principles that sat under our framework. First and foremost, you've got to have the ability to sustain a competent, high-performing workforce. We'd had a situation in the northwest, which is a less populated area, where we were paying $2,500 a day for locums and had been doing that for a long time. Locum allied health providers, $600 a session. They'd come in, they'd do their thing like podiatry, they'd chop a few toenails, things that assistants should and could have been doing, and then they go again. They didn't talk to the local teams, they didn't share information, communicate, we couldn't push people through. So we in our principles said, you've got to be able to do it in a sustainable way, we've got to be able to attract and retain the correct, the type of clinical workforce to do it, and you've got to be able to keep going with enough service volume. Now, for the things that are really technically complex, like esophagectomies, pancreatectomies, AAAs, blah, 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 that's easy because there's an evidence base that gives you magic numbers. At one level, it's easy. At another, when you tell a clinician that we're not doing it in their hospital anymore, that's another story. But minimum service volumes are also about not just your clinical competence, but your clinical comfort in doing something and feeling like you're doing a good job. It's about the willingness of your team, who may not be as comfortable as you are in having a go at this procedure or that procedure. It's about your credentialing, it's about your licensing, it's about your medical insurance. So there's a lot of things that actually go into determining what volumes we were going to maintain for special services. You've got to be able to consistently deliver a service, and you can't rely on small numbers of clinicians to be on call 24 hours a day, 365 days a year. It's not safe, it's not sustainable, and we had to redesign our key person dependent services. So we based it on an assessment of number, range, expertise, so looked at our services and how they were distributed. So that's a service map. And that was a really surprising thing coming into our process. We didn't actually know who did what where. We thought we did, but when you actually came down to it, we didn't know which clinical services delivered which types of clinical care and whether that was appropriate. We also looked at population size and where we thought we'd need things into the future, likely demand, whether you had all of the interdependencies in place. So, for example, if you've got interventional cardiology, you should have cardiothoracics either on site or within a reasonable distance. Same for your advanced bronchoscopies, those sorts of things. So you had to actually have the right mix of other specialties. It was clinically led. So although I was the clinician lead for the role delineation, I had clinicians across the entire system that I was working with to develop our role delineation framework so that when it came out, it wasn't a bureaucrat sitting somewhere outside their specialty that had done it. It was actually within the specialty that they got delivered. So here's an example of what it might look like to have a role delineation. This is trauma. We didn't have level 1 or 2, that was fine. A level 3 is the sort of service I work in clinically, which is a rural health centre on Bruny Island, which is off the south coast of Tasmania, accessible by ferry only. After 7 o'clock at night, you've got to get choppered in or out or on the police launch. So for us, we had to be able to stabilise people prior to retrieval. Helicopter landing site doesn't mean a big H on a special pad, just somewhere flat where they could bring the helicopter in. Had to have a medical doctor in attendance within 30 minutes and an on-site RN available 24 hours. Next level up was a level 4. So that's like a level 3, but you've also got to have the ability to do your emergency resuscitation, some holding capacity, consultant surgeon and anaesthetist within 30 minutes. A level 5, up another level again. They're for our major trauma patients, but excluding some of our more technically complex surgical areas. So if they had a neurosurgical or cardiac or cardiothoracic need or paediatric or they're an obstetric trauma, then automatically they were not appropriate to be treated on site there. They were stabilised and sent. You had to have interventional radiology, MRI and the appropriate specialist workforce. And then all the way up to level 6, which was for our full spectrum of clinical care, on-site neuro, cardiothoracics, etc., interventional, intravascular radiology. So what that allowed us to do was a couple of things. The first thing is to say that this is what good looks like in terms of how you grade a service system, all the way from the nothing at all to the what we think we need to have access to. The next part of the process is to then develop a clinical services profile, which is to actually allocate your services to that framework. So, we've got our 1 to 6 for trauma, that's the role delineation for it. The profile actually says who's going to do what. And so for some of our services, in Tasmania, we're a level 5. Our level 6 is interstate. And that's appropriate because with 500,000 people, we can't do it. Other things, in the ideal world, we would have been a level 5, but because of service interdependencies, we had to beef up our capacity. And vascular is a really good example of that. We've got a vascular surgical service. For those who know, the King's Fund says you need a minimum population size of about 800,000 to safely and sustainably have vascular surgery. For us, being on an island, far from subspecialty surgical services for vascular, and with the service interdependencies with vascular, which we needed for trauma and for cardiothoracics, we had to have a vascular surgical service. So our service we had to design in such a way as it could meet the needs of people, but any of the really technically complex stuff, so for us thoracic vascular surgery, we said, well, that part of it has to go interstate and we'll do these bits. So there was a bit of toing and froing and nuancing and recognising the fact that, like you, we're different, but we still need to stick to the plan. So the way we made the decisions about who was going to do what, again, lots of consultation, a lot of analysis of patient outcomes and against a quality framework. So, for example, on the northwest coast, they're doing knee replacements, their length of stay is pretty good, the number of separations they were doing, the volume was okay, but their cost was about 20% higher than an hour and a half up the road at Launceston General. So we had a choice to make. Do we keep doing knee replacements up in the northwest when we've got 100 people on a waiting list? We recognise if we did them up the road, we could get 120 people through. So those 20 people get a service that they otherwise might not get. So being able to do that sort of decision making based on outcomes versus effectiveness outcomes, some safety issues. We had big issues with our maternity services and some of our outcomes for little babies. So being able to say, well, based on these neonatal outcomes, we're not going to be providing this here anymore. Instead, we're going to strengthen our neonatal emergency transport services and make sure that we can use transport accommodation to get people to the right place faster without saying right place, right person, right time. Patient experience, obviously, being able to sell the idea that better access to care is different to access to better care. And helping people to understand that just because you didn't have an ICU at your hospital that you used to in the 60s, that wasn't us taking away a service, because instead we were putting a helicopter landing pad and a big chopper on top of the major tertiary service. And our light bulb moment for consumers was when they realised that helicopter landing pad was for them. It wasn't for the people living in Hobart. They don't need it. They already live there. It was for the people that were far away rurally, and this is what the trade-off was going to be. This is what they were going to get instead, and plus some very clever subspecialists coming up in the chopper to look after them and bring them back home. So trying to explain those sorts of things was really important. In terms of methods, again, looking at service mapping, analysis of data, evidence review, clinical consultation, lots more consumer forums, lots more people throwing things at the minister, getting very, very angry, but working through those processes. Lots of work with the media so that they didn't scuttle what we were trying to do. And so this is an example of the clinical services profile where we recognised that with trauma, we needed to have a 6, but we actually really only had a 5.5. So this was a service gap for us as a state. So we fixed it and decided if we're going to be in the business of trauma, it needs to look like a contemporary trauma model, and this is the things that it needs. So 18 months later, I don't want you to think it's a happily ever after. Nothing ever is in health reform, and there's been lots of bloodshed. And things that seemed really simple to me and no-brainers weren't for a variety of reasons. Things that I think went well were the organisational restructure, so taking us to being one hospital with 4 campuses and getting people to understand the need to work across sites has gone really well for us. The idea that if you recruit an ENT surgeon on the northwest coast, that's not safe, it's not sustainable, it's a sole key person dependency. Instead, recruiting to Launceston and then providing that as a service on an ongoing basis and strengthening transport and accommodation the other way has meant that we've improved our ENT outcomes. They get access to specialists who are actually have the benefit of a peer network, which they didn't have before. And I think that's been an improvement. Commissioning, I think, has been a good thing, being able to say, well, it's up to you. We're not interfering with your autonomy. We're just not going to pay you to do an esophagectomy on the northwest coast. That's a bit of an exaggeration. Actually, it's not quite. I'll get to that. Clinical leadership. It's been good to have a mechanism for clinicians to lead and to take on the responsibility for developing service models. Previously, they were very frustrated because the bureaucracy kind of made all the decisions. An opportunity to sit at a table with all the relevant players for clinical pathways and to actually have more transparent performance monitoring. Things that haven't gone well. Governance and management. That bloke's Frank Nicholson. He's the head of our Staff Medical Association at the Royal. He's a geriatrician. And Tasmania's health system is in the balance. And this was taken on October 11th, so before I hopped on the plane to come over. And this isn't about the plan. There's no disagreement about this is the way services should be distributed. It's about the fact that we didn't follow up on our plan with good management structures quickly. People bickered about who was going to be the manager and whether they should be based in the north or based in the south and how the governance was actually going to work. And what we're finding is there's a frustration because here's what good looks like. We're all on the same page. We all agree. But who's actually the go-to when we have problems making it happen? Who's sorting the issues, which is an inevitability in this sort of thing. So I guess that's for, in hindsight, know that at the same time or faster or whenever you can. The other threats to the process are advocacy and autonomy, which you could call tribalism. Tribalism is really, really difficult in this, and 3 examples I'll bring up are upper gastrointestinal surgery, burns, and neonates. So upper GI surgeries, should be a no-brainer. Esophagectomies, pancreatectomies, we're only 500,000 people, it should be a single-site service. Well, in fact, in Tasmania, we have 5 sites that do esophagectomies and pancreatectomies. And, for 500,000 people, you'd probably be doing maybe 10 a year esophagectomies, maybe 15, give or take, for pancreatectomies. Don't know, maybe you've got more or less cancer than we do. So you think, we'll bring the hepatobiliary surgeons together and we'll agree which site is going to be the site. The North has an intensive care that's staffed 24 hours, but had a really low ventilation rate. About 20 to 25% of their patients are mechanically ventilated, which, for those that know, is really a bit too low. It's putting it into the territory of being a HDU. In the South, we had bed block. So our ICU, we were cancelling elective cardiothoracic cases. We didn't have money for more infrastructure, more staff in the South. And we were sitting at about 60% mechanical ventilation rate. So that's our ICU HDU, which, for those that know, is a bit high. So we decided to put elective hepatobiliary surgery in the North. It's appropriate. They've got interventional radiology, all the rest of it. It'll increase their throughput of elective mechanically ventilated people. Well, no way. You can't do that. I refuse to travel the 2 hours up the road to deliver that service. I think it should be in the South because we're doing the trauma, and if we don't have upper GI electively, then we're not going to have our skills anymore. Yes, you will. You can go up the road and do it. I didn't sign up for this. It's not on my statement of duties. That's fine. We'll renegotiate your contract. So on and so forth. Let's get the endocrinologists involved because we need them here for diabetes management. So it got really crazy, and we hit an impasse on that one. Burns, again, 500,000 people. Our burns centre, we've got a statewide burns service, which is 3 or 4 beds at the end of a ward. It's sort of shut off with swinging doors when it's not in use. An hour away in Melbourne, we've got a state-of-the-art burn service. It's like going into an airlock and there's no bugs anywhere. You've got OTs who do pressure garments all the time. They're fabulous at it. They see kids. They look after the full spectrum. But no, you couldn't possibly put somebody in a plane, stabilise them and send them to Melbourne. We must have our burn service here. We disagree with the Royal Delineation framework because it didn't end up the way we wanted it to. We didn't see this coming, that the clinical services profile would say, actually, you're a level 5, they're a level 5, and off you go to Sydney if you've got, or to Melbourne if you've got a really big burn. And then the third is neonates. In Australia, we've got a National Service Improvement Framework for Neonatology that says if you've got these features, 32 weeks, those features, 34 weeks. So pretty standard stuff. We have a hybrid neonatal intensive care unit, paediatric intensive care unit. The guys in the smaller centres really resented having to send mothers and babies, the little ones. So they wanted to keep their 30, 31 weekers, their sometimes 29 weekers, because they were good at it and because the patient's stable. The flow-on effect from that, though, is if you take that volume and you put it elsewhere, there may be some safety issues, there may not. They might be quite good at managing them. But you starve your only centre of volume, and that threatens the viability of that centre. So you actually need patient flows, not because you as a doctor are clever or not clever. It's actually about not about you. It's about the entire system and the impacts on the system. It's not about how clever the hepatobiliary surgeon is with a knife. It's about the ICU, actually, and the ability to sustainably recruit your ICU RNs to this site up here when they're not getting enough ventilated patients, and a whole bunch of other things. So I guess in thinking about our reform process, it's Taz, the most difficult thing, and still is the most difficult thing, is getting us as clinicians to think outside ourselves and to not take this personally. That reform is a messy business and it doesn't always go the way that you want it to, but it's not about you, it's about patients and how we deliver better care for them. Thank you.